Hi, I'm Dr. Kimberly Turner, and welcome to Moms, Minds, and Medicine Inside Maternal Health Research. This podcast is your trusted companion on the pregnancy journey, where we break down the latest insights, answer the real questions, and empower you to make informed decisions every step of the way. Hi, welcome to Moms, Minds, and Medicine Inside Maternal Health Research. I'm your host, Dr. Kimberly Turner, a board-certified OBGYN with 30 years of clinical experience, and I am thrilled to welcome Dr. Byron Edmond, a board-certified anesthesiologist with probably as many years' experience as I have had in clinical medicine. So, Dr. Edmond, welcome to Moms, Minds, and Medicine. How are you?
I'm outstandingly well. It's a beautiful day, and it's great to be here with you.
Yes, you're our first in-person studio guest, so that makes it even more exciting.
It does. I hope I set a good trend.
Yeah, so just to begin with, can you even tell us what an anesthesiologist is?
Right. An anesthesiologist is a physician who's a trained professional whose emphasis and receives special training in terms of the relief of pain and the management of resuscitations and the management of a patient's well-being when they undergo surgery of any type or any form.
Excellent. So you said the word resuscitation. Mm-hmm. Let's tell the audience what that actually means, not in a scary way, but what happened? Why would we need a resuscitation?
Well, resuscitation basically involves assessing when patients' vital signs and when their bodies are doing well and when their bodies are not doing well, and being trained to give medicines and in a timely way to help save their lives.
Excellent. So I have two questions. One is, what led you to want to be an anesthesiologist, and talk a little bit about your training? And then second, can you tell our audience why it's important to have an anesthesiologist around when you're having a baby?
Absolutely. I chose anesthesia because in medical school, I found that I felt the most alive during times when patients were trying to die. So if you look at the emergency shows and TV shows, there's always this episode when they say, hey, the patient's flatline and they have to do these things to bring the patient back to life. Well, in those periods, I found out that when everybody else was getting really excited, calmness came over me. And I was able to think clearly. So I do well in very high intensity or high risk situations. The other thing that I think when we look at the training for anesthesiologists, all anesthesiologists have training in how to take care of mothers surrounding pregnancy, and how to prevent pain, and how to do how to save lives for mothers during the delivery period and after the delivery period. We have special training for that as part of our standard training in anesthesiology. But one of the things I think that I'd like people to know, the mothers to know, is when you think about anesthesiology, anesthesiologist, I want you to think of someone who's a member of the team with the obstetrician, and we serve a support role. And a good anesthesiologist is someone who can work with the obstetrician in order to guarantee that her patient gets the best care possible.
Yes. So one of the reasons that we thought it was important to bring to light the role of the anesthesiologist is many women don't really think about what happens during the labor, and they don't always prepare and may not even know what types of options are available for pain relief, for emergencies. So can you give us an overview of what it looks like in labor when you ask for pain relief, or what it looks like in labor if you have a medical condition?
Right. When a mother comes in and they're asking for consideration for some pain relief, there are different methods that we can use. I'll mention the most common first, and that is when the mother's coming in labor. oftentimes we use something that's called an epidural. And basically, what it is a very thin piece of tubing that's almost, imagine the smallest type of tubing you can make. And we put about 1.5 inches of it in the soft tissue of the mother's back. And we attach that tubing to a computer that gives a certain amount of medicine to that mother's back. When we inject that medicine into the mother's back, it bathes the nerves that supply the front of the mother's stomach and makes it more tolerable and decreases pain for when mothers begin to labor. That's the epidural is one of the most common ways that we do use for anesthesia. There are other ways that involve giving IV medications. There are also ways sometimes that we can have mothers breathe in, believe it or not, laughing gas,
Yes.
in order to get you through some of the most trying times of labor. That's for a person who's having a vaginal delivery in a standard way. In emergency situations or in situations where we have to do what's called a C-section, where we actually have to have the obstetricians help the child come out surgically. In those situations, we can also use the epidurals that were placed for the laboring part of care. And we also have another option, which basically involves us taking a microneedle, a super narrow small needle, and giving an injection in the small of the back with about a tablespoonful worth of medicine. And it kind of numbs you up from your belly button down and makes it so that they can operate below your belly button. And the mother will lie in the operating room on the table, participating in the child's care. Of course, she won't be pushing, but when the child comes out, she'll be able to hear and engage in the birthing process.
Is an epidural safe? Patients used to always ask me things like, can I get paralyzed from an epidural? Is that really true?
The reality is epidurals are being used in some places almost in half of the deliveries. So because of the sheer number of times that the epidural is used, it's an extremely safe and a tried and true method to relieve pain for mothers. In the super rare instance, there may be times where you can get some type of a nerve injury, but the reality is if that happens, it's so rare that it's almost something that will make the scientific literature because it's so rare. So these things are extremely safe. I venture to say that everyone who's done heavy research and look at epidurals, will suggest epidurals for their families as an option, definitely for delivery.
Right. I know in my 30 years, I never saw anybody become paralyzed from an epidural. Right. So I think that's a bit of a myth.
Right. I think what happens is we want to say it's a myth, but then they teach us in medical school something's out. But the reality is when I say it has to be at least maybe 1 in over 100,000 or 1 in almost close to over 100,000 that anything temporary happens. Problem. Now, remember when we do put the epidural in, you may have a little soreness at the place where we put the epidural in, but that's kind of common and it resolves shortly. But the actual long-term damage from an epidural is extremely, when I say extremely rare, I've been doing this over 32 years, and I may have only seen, one time.
Right. Well, let's talk a little bit about what patients need to know that are considering this type of pain relief. Are there times when we cannot give them this kind of pain relief?
Yeah, there are some patients who are not candidates for it. Mainly if a patient has bleeding issues or problems with their blood in terms of bleeding. That's a situation where we wouldn't necessarily want to place an epidural in. We also have situations if you're coming in and you're in a crisis situation and your blood pressure is already low, then we wouldn't want to necessarily do it in that situation. If you have an infection on your back or somewhere on your back, we don't offer it in that situation either. But outside of those 2 or 3, those are situations that everybody else, for the most part, is a candidate.
Okay. So you said like a low blood pressure, sometimes
Right.
you can't have it. Do things like the IV fluids that are somewhat standard in hospitals
no,
help? And is that a requirement?
My fault. Let me clarify that. The reason I said a person who comes in with a low blood pressure, if that person's coming in with a low blood pressure because they have an infection raging in their body,
Okay.
or they're already bleeding, and they're in a crisis situation, then epidurals are not necessarily looked upon favorably. But those are for patients who are coming in crisis. Now, one of the things I do want to mention, you might say, is, hey, when the mother comes in, why do we place an IV
Yes.
in the mother?
Yes.
Yeah, because a lot of people don't like IVs at all, and I am one of them. But the reality is whenever we have a laboring mother, we place the IV in. A lot of times it's because we want to get some baseline lab work as they come in, so we can gauge to make sure that the mother is transitioning into the active labor period in good physiologic standing. Or with, for us as anesthesiologists, because we're going to be placing a needle and potentially using needles around the patients, we always want to focus on the lab values that correspond with how much you will bleed. Mm-hmm. If a person comes in and shows us that they don't have a high enough platelet count, which are the things that help you form blood clots in your blood, that's a sign for us to watch for that patient and know about that patient. But other than that, I think that's why we place an IV in. We place it in also as a safety measure. If we know that a mother's coming in and has a placenta that's not positioned in the right place, or we know that the child hasn't turned, or we know that there's a higher risk for this mother to require some type of anesthesia involvement, then that's the type person. So if a person comes with a history of having problems in the past, mostly we put an IV in that situation as well.
All right. So the IV, we get the blood work from the IV. Mm-hmm. We have it there in case we need for emergencies. Mm-hmm. And if I'm recalling correctly, sometimes the blood pressure, or many times, it drops a little bit after the epidural.
Right. And from an anesthesia standpoint, along with the safety measures for having it in there just as a routine labor, when we place an epidural in, one of the effects of the epidural can be a drop in the mother's blood pressure some. And so to offset that, we give fluid through the mother's IV. So a lot of times they'll say, hey, the team will make the decision, including the mother, that the epidural is needed. And as soon as they make that decision, usually the nurses in the room will give a little bit of extra IV fluid so that when the epidural sets up, it doesn't drop the patient's blood pressure much.
Right. Right. So now here's another thing that patients used to get a little bit angry about. Why can't you eat when you're in labor in a hospital?
When you're in labor in a hospital, you can eat. You just cannot eat the way you want to. So when a mother's in laboring in a hospital, what we try to do is limit the diet to clear fluids and clear fluids. You can have Jell-O, you can have some broths, and you can have water. But what happens is if you eat a large meal and we go into an emergency situation, what can happen is if we have to place you asleep for any reason, there's an increased chance of the contents from your stomach coming up into your airway and causing a medical crisis. So that's why we don't have mothers eat hearty meals. But as soon as the child is out and you're over on the floor, you're welcome to have whatever meal that you want. But we ask while you're laboring to keep it down to clear liquids so that it gives us a lot of flexibility in how we can engage to support you during the laboring process.
So here's another hot question, I think, that patients would say that I think is mostly myth. From your perspective, does the epidural slow down the labor in any way? Or does it increase your chance of needing a surgical delivery like a cesarean?
Actually, it doesn't. And it's been very well studied that epidurals do not slow down the delivery process. You can split hairs, you can divide the laboring process into two sections. The early part, it really doesn't hinder at all. Sometimes, depending upon the medicine, the pushing part can go just slightly longer. But the reality is that the outcomes for the children and the outcomes for the mothers are exactly the same. The mothers and the mother, I'd say the mother and her team should not necessarily make the decision when to ask for an epidural based upon it slowing down the process. The whole goal is that if we get an epidural on board, in my experience, when the mother's comfortable and she's about to labor and recover and get ready for the part of delivery where she begins pushing, it's a much more, I guess you could say, agreeable and supportive event. It doesn't slow you down. It just takes away the pain and the discomfort. You still feel the contractions. It's just that the contractions will come away so that you can rest and so that you can catch your breath before engaging in the more active part of delivery.
Right. I think as a mother and as someone who took care of mothers for so many years, people don't always realize exactly how painful it is. And I'd say at least 90% of women have significant pain. And so epidurals are such a great way to relieve pain, and they're so safe. So thank you so much for bringing all of that.
They are very safe, and they are a great way to relieve pain. But the main thing, if I'm talking to you, and allow me to address you like a family member.
Of course.
So if I'm talking to someone in my family and literally explaining the epidurals, I tell them, hey, you would not let me do a hernia operation or fix a hernia or take your appendix out with no anesthetic, without giving you something for pain.
Right.
Why, if we have this as a safe option for mothers, just consider it, take it into consideration when you do it. And I think that's what I tell people. If you're prepared and you understand the birthing process, the main thing is that I'd like the audience to do is to take it into consideration and understand that it's here if you desire it, and it has a proven track record for safety in our community.
Well, you mentioned the team. You mentioned the hospital team, and you also mentioned the patient support team. So the anesthesiologist is such a critical member of the team, and they see things slightly differently than providers like myself sometimes see. So talk a little bit about what else you guys look. You talked about vital signs and being an early intervention for emergencies and
absolutely
problems.
When as part of a team, of course, the obstetrician is at the head of the team and really riding side by side with the patient. Okay, and so ideally we'll have patients and the obstetrician discuss how they want to manage the delivery process, whether or not they want to bring anesthesia involved into it or not. A lot of times, on a lot of floors, patients will present with a history, and there's some catchwords to a patient's history that make the anesthesiologist automatically come and at least do an interview.
Yes.
So we are kind of like, actually look at us as troubleshooters. Some people might look at us as guardian angels. We're kind of there after we put the epidural in, but we're not there. But the reality is once we put an epidural in, that floor is actually monitored for 24 hours until that child comes out. So you won't necessarily see us coming in, every 20 or 30 minutes like the nurse, but someone in the anesthesiology department is aware of really every patient who's on the floor, every patient who's having problems on the floor. And as part of the anesthesia team with the obstetrician and the labor and delivery nurses, we meet on a regular basis to identify patients who may be having problems or who might need anesthesia involvement. So my role, I look at it as a guardian angel. Guardian angel, sometimes he comes in, he puts a simple epidural in, and he just circles around on the outside and everything goes fine. But then you have the guardian angel who puts that epidural in, and circles around on the outside, hears the patient's not doing well and starts to stay a little closer to the situation.
Sure.
And then if a crisis comes, he comes in and he or she comes in and actually looks like it's something that they've been prepared for and they've done 1,000 times.
Right.
So we are trained to kind of get closer and closer and gravitate towards the patients who are on the floor who are having problems. That's for active anesthesiologists.
Right.
And I'm an
great.
active anesthesiologist.
Yes, you are.
Through training, I even if I don't go in the room, I'll ask the nurses how the patient's doing on a regular basis. When I'm on call.
So that's excellent, and I couldn't agree more. Having been colleagues with you for labor and delivery, emergencies, and regular deliveries, but the patient's family team or core team, support team is what I'm trying to ask. Do you ever get a chance to meet them before the labor, and what does that look like?
That's very interesting. Not in the current system we have, not often, but there are patients, if the patient is identified as potentially being a difficult delivery, or say they have a history of a difficult delivery, the obstetrician will request an anesthesia consult. And when we come in that situation, we get to sit down with the patients in a nice controlled environment and ask all our questions and have the patient ask us all the questions. And it's something that occurs that I really wish would happen for all mothers who are coming in. I think it would be great if there was a means for the mothers to simply, hey, not in labor, this is a week or two before delivering, calling in and to the at least the anesthesiologist, who's an important but the least and I say engaged until the mother comes through the door. And I think that would be a great opportunity to share knowledge in a controlled environment. I say that based upon over 32 years experience. And when the mother's laboring, they're with me, but they're calling for the epidural, or they need the epidural, or they're transitioning from being home to the hospital. The couple is figuring out who to call and when to call. And I come in and I know how to get the information from the chart. I know the proper questions to ask. But one of the reasons that a good anesthesia interview is important is because it lowers the stress level. It informs the mother in a controlled fashion when the mother's not necessarily being pressed.
Sure.
Because when we go into the heat, as you've seen, and sometimes when I say, and I've seen Dr. Turner go in and really deliver a child within a matter of minutes. I mean, less than 3 minutes. Hit it, patient comfortable, baby out literally within almost a minute, minute. I've seen her work that fast in emergency situations. And the reality is it's during that time period, we don't have the time to give that education and incorporate that mother into the team as much as I'd like to see it incorporated into the team.
Yeah, that would be really another great focus of research of how to make that more accessible.
Right. I mean, we have Zoom and everything like that. Let's solve the problem here with the Maternal Health Research Collaborative. Get some of the some local anesthesiologists to simply agree to meet on a regular basis and see if the patients, the mothers, want to take advantage of it and see what the impact is in terms of the benefit of the outcome. My outcome for the audience today is similar to the outcome I'd like to see if something like that were done. That's a project like that was done. I'd like to see the mothers have a lower level of stress, I'd like to see the team, the team meaning the mother and her support team, have a higher level of control for the situation. And I like to see everybody get there and understand that we're trying to make some, we're trying to improve maternal health so we can have healthy pregnancies, so that we can make healthy mamas, and so that we can have healthy children to impact the community.
Yes. Well said. I didn't
get that.
Yes. No, that's perfect.
That's the vision for this.
One last question for this segment. I would like to bring up, how do we handle when we, the medical providers, believe an epidural is needed because of medical reasons? Let's say there's twins. Let's say things are looking like we might need a C-section.
Right.
I know I have an approach to that. I'd like to hear your perspective.
Very interesting question. Everyone has their plan for how they'd like to deliver. And one of the reasons that people will not get an epidural is if they refuse an epidural.
Sure.
You know,
sure.
But if a person refuses the epidural and we transition into a crisis situation, that really leaves us limited. A crisis situation, say we have to go for a C-section or emergency C-section for some reason, then that limits our options of how we can safely take care of the mother. So it kind of limits our option to simply putting that mother to sleep with a general anesthetic. Kind of like breaks some of the control link that we try to maintain surrounding labor and delivery and stuff. But if a person tells us that they don't want to have an epidural, of course, it's their option. If the obstetrician believes they should have an epidural, then we're respectful. And we for me, if they say absolutely not, I don't want to have it, it's not part of my plan, I say okay. But if I see something in the chart that suggests they're going to have an issue, remember, I'm gentle like a guardian angel. I'm going to go get that history. I'm going to look at the person's airway. I'm going to do everything I would do as if they were going to need me to be involved. And then I'd hover. Meaning, even though she's chosen not to do the epidural, the reality is
a close watch.
That she's going to be, that's a very close watch where the nurse will have my direct telephone number and they will know where I am at all times in case there's a crisis. But I will discuss it with the mother. But the reality is part of getting the best outcome, I think, for mothers is to maintain their autonomy. So if you notice, I never said we're going to make them do this. Or you have to have an epidural. No, it's an option. Women been having babies without epidurals for they had for millennia,
centuries,
up until about 100, up until about 50 years ago and stuff. And but there have been issues that couldn't be addressed. But if we have modern technology that we can integrate in a community-sensitive manner, then why not use it? If we can get you the same results, but have you better rested with a better child engagement in almost the same outcome.
Excellent.
Yeah.
Well, I have so many more questions, but we do have limited time.
Okay.
Do you have one take-home message that you'd like to give the audience? You kind of gave it, but do you have anything that you want to leave us with?
Other than she's a great doctor, and I've seen it,
Thank you.
Yeah, well, honestly, it's
Ditto.
Like I said, it's one thing to tell you that she can do it. It's another thing to have a witness who's seen it from 3 feet do it. Number one, I'd just say that we need as many healthy children in our community as in America as possible. And I think that you should not, as you make your plans on having children, and as you go through your pregnancy, I think that there are platforms for up-to-date information on how you can navigate and move around in that situation to make sure you get the best outcome. When you're delivering a child, fear shouldn't be the first thing that comes to mind. It should be joy. And I think that this show hopefully will give enough information to move the mothers to focusing on the joyful aspect. But we want joyful but informed, okay? Joyful but informed as we have a child.
Yes. I believe you had a resource too to help patients navigate an anesthesia resource that we talked about briefly right before we came in.
Absolutely. And what's happened is especially within the past weeks, the New York Times put out a major expose on pain during labor and delivery in America, and the fact that 1 out of 6 times mothers aren't getting adequate pain management.
Wow!
But one of our organizations, the Anesthesia Patient Safety Foundation, which is really the group of kind of like nerds in anesthesia that do all of the studies that deal with how to deliver anesthesia more safely. They came out with a great article that gave us recommendations on how anesthesiologists can step up and do a better job of recognizing a concept. And what they called it was wellness bias. And wellness bias is what happens when a physician will come in and the patient looks so good that the physician will automatically look past the symptoms that they're seeing, or the red flag symptoms that they're seeing in the patient's chart or the patient's history. The other thing that it also mentions is about how we may have maternal physiology. I'll say it kind of blindness, whereas some providers are not familiar enough with the changes in a laboring woman's body to be able to recognize when that laboring woman is having an issue. And the reason that happens is because they're looking at the mother. All mothers do well. It's a joyous situation. It's a joyous occasion. Okay, the heart rate may be up to 110, but the normal mother's heart rate is only supposed to be around 100. If it's at 110, that means there's an underlying process going on. If the mother's temperature is up, it actually 20% of the time with mothers, if they have an ongoing infection, they will not spike a fever. So we have to train ourselves and providers on how to better recognize and the vital signs and the exams that go along with mothers having issues. But I liked it because it was both the New York article was last week and the Anesthesia Patient Safety Foundation article was this week on how we can do better.
So we will share those resources with our audience as well. Well, I am so happy that you came to the studio today, and I'm so happy that patients still have you as their guardian angel. And just thank you for all that you do have done and will do in the area of medicine. And we hope to have you back for a second episode.
Look forward to coming back.